Hello, my friends. Welcome back to my channel with a new video. And this is a part 4 of the series of overview on acute pancreatitis. And we left out in the last part with IV fluids, and it was quite a comprehensive coverage on uh, uh, which IV fluids, how much, for how long, why not colloids, what are the endpoints, the advantages of aggressive fluid therapy, the disadvantages of aggressive fluid therapy, and so on and so forth. Now, in this particular video, we are starting with the pain management, and you know, this forms a cornerstone as far as therapy of the pancreatitis is concerned in the form of the paracetamol as maybe the first agent. Opioids also should be thought of along with the NSAIDs. There is a definite evidence of uh, kind of going for epidural analgesia in these patients with this study where they studied about 352 patients, and the endpoints were ARDS, the AKI, and the mortality, and there was definite protection for these kind of complications. So mind you, in very selective patients when these kind of opioids and the NSAIDs along with paracetamol is not working, obviously we should think of epidural analgesia. Here I would like to mention about the rectal suppositories or rectal diclofenac as the use of NSAIDs in this kind of patients, which definitely have some evidence for the use of these particular agents in acute pancreatitis. So there were two meta-analyses with 6 RCTs and the 12 RCTs, which actually compared NSAIDs and opioids, which were found to be equally effective. So there were two studies, as you could see here, which have been mentioned. As I said, opioids, it will provide a potent analgesia, and it is effective in managing severe pain. It has a rapid onset of action and reduce the visceral pain. There is of course a risk of respiratory depression, constipation, and potential for dependency. And but if the patient is in ICU, obviously we need to prefer that. As far as NSAIDs and acetaminophen is concerned, is IV diclofenac and paracetamol are definite natural choices uh, uh, as an alternative to opioids. In the patients where opioids are contraindicated, obviously we would prefer NSAIDs and paracetamol. They will have an anti-inflammatory property as well, but we need to be very careful about the patients who have renal impairment and of course history of gastric ulcers. So as I said, the diclofenac suppository works very well in this situation, and you may please kind of consider using this in this particular clinical context. As I clearly said, epidural analgesia, thoracic epidural, which should be explored for the pain management, especially when the patient is admitted to ICU, and there has been quite a significant evidence to suggest even the benefits in terms of ARDS, AKI, and the mortality. Uh, the first and foremost of the quality indicators in ICU when we take rounds on a day-to-day basis uh, in the form of the fast Herx bid, the F stands for feeding, and of course the nutritional support with early enteral feeding where the NBM should be kind of there should be a initial rest of say about 48 hours, but within 3 days we need to actually start. And there is a recent research which has shown that early oral or enteral feeding, which results in the shorter hospital stay, and this is a conventional teaching to each and every intensivist who takes the training during their kind of courses. So in a mild AP, you have an early oral feeding initiated within first 24 to 48 hours as tolerated. Initial oral feeding with a low fat solid diet, and then you can stepwise increase it to liquids or a solid. And if EN is administered by the tube, there has to be a continuous infusion which is preferred over the cyclic or bolus administration, and that is what we practice in our ICU as a continuous feeds rather than the boluses of feeds. As far as moderately severe or severe AP is concerned, enteral nutrition is obviously known to mitigate the problems of infection, and the oral feeding which maintains the gut mucosal integrity and prevents the translocation of the bacteria, which we call as a concept of gut rousing. And there's a meta-analysis of 8 randomized controlled trials involving about 380 patients, which found a decrease in the infectious complications, the organ failure, and the mortality in patients with severe AP, with those as compared to those who were initiated with TPN. As far as TPN is concerned, it has to be considered only when enteral route is not possible or not tolerated or not meeting the caloric needs, and of course a nasogastric tube as well as a nasojejunal tube which can be preferred. The initial energy requirement is to the tune of 15 to 20 kilocalories per kg per day, with a protein requirement of about 1.2 to 1.5 grams per kg per day. And with SAP, with the intra-abdominal pressures, which are about 15 to 20, the EN is performed by the nasojejunal tube with starting volumes of about 20 ml per hour under the continuous abdominal monitoring. So, uh, in terms of abdominal compartment syndrome, of course, EN should be discontinued and it has to be switched to TPN. So, there are hardly any contraindications. So, of course, you have a ACS, or you have an obstruction, or you have a perforation, uh, or a recent resection anastomosis surgery within the last 24 to 48 hours, or even for that matter, till about 5 to 7 days. These are the only absolute contraindications wherein you have to actually prefer enteral feed. As far as nutrition, as I said, is concerned, the starvation will give rise to gut failure and translocation. And here there was kind of a study which was early onset of the feeds versus the late onset, and it shows that the length of stay was lower in the early initiated group with less multi-organ failure and the complications. As I said, there were two meta-analysis with early diet, which will cause definite shorter length of stay in the hospital. So, if the no oral diet within the first 3 days, we need to actually go ahead and do a NG feed. So the message is that the patient has to be initiated with the oral diet, and if they don't, then of course go ahead and put a nasogastric tube, but initiate the enteral feeds as early as possible. There was one trial from India which was like a hunger based approach, early in about 6.3 days versus late, which is after 7 days, and they also found that there is a bearing on the early enteral feeding and lesser complications, lesser morbidity, and lesser mortality. As far as antibiotics are concerned, the prophylactic antibiotics in patients with severe AP is not recommended. Prophylactic antibiotics in patients with sterile necrosis in AP is not recommended. What are the indications? When there is infected pancreatic necrosis, infected pseudocyst, that is infected abscess, or SAP associated with cholangitis, or hospital acquired infections like pneumonia, line sepsis, UTI, so on and so forth. So these are the only probably three indications where you would start antibiotics upfront. But the role of prophylactin, we'll discuss a bit on that, about how can we go about antibiotics, especially based on the procalcitonin, and that I will discuss. So selection of antibiotics which is sufficient to penetrate into pancreatic tissue or necrosis, which is recommended. So the natural choices are carbapenems, quinolones, metronidazole, third or fourth generation cephalosporins, and routine administration of antifungal agents is not recommended. So with a due respect to our gastroenterology colleagues, I could see that there are gastroenterologists who have a overzealous approach of starting antifungal as a blanket policy for any patient who has pancreatitis or the patient who is not doing fine. If the patient is on noradrenaline, that doesn't mean that this patient needs a antifungal. And I often see them on echinocandin, so that is something which is not recommended unless you prove that the patient has candidemia. So it is only used in invasive fungal infection or definitive fungal infections, and of course few risk factors. As far as prophylactic antibiotics, as I was telling you, uh, that there is no role, and there were meta-analysis of about 7 studies, and the carbapenem prophylaxis, which will decrease the chances of infection, the translocation of bacteria. It will decrease the chances of pneumonias, UTIs, and other infections, but it will probably does not have effect on uh, the pancreatic infection per se. And of course it may not actually really directly affect the mortality and the outcomes of the patient. So you may have the benefits of carbapenem in the for the patients for other infections in the body rather than pancreas per se. So that is the message. That's all for now. uh, I think I'll stop here, and we'll meet in the fifth and the final video on acute pancreatitis next time. That's all for now. Thank you.